Good evening, everyone. Thank you for joining us. So, in the interest of time, we'll go ahead and get started because I think that this topic is going to be one that we'll be able to talk about for quite some time. Um, I am Dr. Latanya Washington. I'm the president of the Bluff City Medical Society. Welcome to our um, community webinar series where we'll be doing COVID-19 update, the old, the new, and the future. Our purpose for this event is to give an update on COVID-19. We've been going through this pandemic for over a year, and so it's important that we talk about the various changes that have occurred within the pandemic and answer a lot of your questions. And just so you know, we won't be all doctors talking to you today. Well, we'll all be doctors talking to you, but not all physicians talking to you today about this COVID-19 pandemic. So that is very important for us today. So as I mentioned before, we are on social media on Facebook, Instagram, and Twitter. We are posting live, doing live stream on Facebook. So if you're on Facebook, then certainly hop on, share the video so we can expand our reach, and we'll be most appreciative of that. So again, our topic tonight is COVID-19. We're giving an update after being in this pandemic over a year. I do want to go through some brief housekeeping. We are doing live stream on the Bluff City Medical Society Facebook page, and we are recording this webinar. We have a webinar feature, so the attendees don't have the option to be on camera, but other people in the Zoom will be able to see that you are online. And then we will have a recording available on the YouTube page, on the organization's YouTube page, and on our website after the event, about 24 to 48 hours after the event. We will be taking questions from our audience, so you can drop any of those questions into our Q&A feature, also into any comments into the chat feature, and we will get to as many as possible. And then unfortunately, CME is not available for this event, but we do appreciate all the physicians and healthcare professionals who have joined us for this call. I want to take an opportunity to recognize our community partners. When we embarked upon this community webinar series, I thought it was very important that we engage local organizations who really have a target of getting health information out into the community. So as you see, we have various organizations. We have 2 chapters of Alpha Kappa Alpha Sorority Incorporated, Alpha Alpha Gamma Omega, and Alpha Alpha Zeta Omega. We have the Memphis National Panhellenic Council, the Epsilon Pi chapter of Omega Psi Phi Fraternity Incorporated, the Alpha Delta Lambda chapter of Alpha Phi Alpha Fraternity Incorporated, and the Memphis Links Incorporated. Also, the Memphis Association of Black Journalists and the National Pharmaceutical Association are also our community partners. And of course, we cannot forget our medical community partners. We have been working within these institutions and really supporting the institutions as they have supported us throughout this pandemic and supported our community. And so we're certainly grateful for all of our hospitals, as well as the University of Tennessee Health Science Center and Church Health Center. So thank you all for your support. Again, I'm the moderator. I'm Dr. Latanya Washington. I am trained in internal medicine and pediatrics. I am the physician advisor at St. Francis Hospital, Memphis, and I am also assistant professor of medicine at UT Health Science Center. So we are going to get into the introduction of the panelists, and I will tell you that our panelists tonight are very accomplished. And so I'm excited about having the opportunity to introduce them. So really what I'm going to do is plan to go into give everyone's kind of brief bio, and then we'll make the transition into our panel-based discussion. So the first panelist I'd like to introduce is Reverend Dr. Chuck Lester. He is the executive pastor of Christ Missionary Baptist Church. He has a Bachelor of Arts degree in social work from University of Memphis, a Master of Arts in Religion from Memphis Theological Seminary, and a Doctorate of Ministry in Religion from Memphis Theological Seminary. And that's not most importantly, but the reason he's here tonight is because he is a COVID survivor. And he has a very interesting story that he's going to share with us. So Dr. Lester will be sharing with us momentarily. Our next panelist is Dr. Nico West. Dr. West is Assistant Professor of Pediatrics at University of Tennessee Health Science Center. She also has a PhD in Interdisciplinary Sciences. She does research in pediatric critical care medicine and works within the Center for Health Equity at Le Bonheur Children's Hospital. And also, she is a co-founder of Community Integrated STEM Program at John P. Freeman K-8 Optional School. This is just a small amount of what Dr. Nico does. So she certainly stays very busy. I sent her a message after she sent me her bio asking her how she had time to do all of these things. And then Dr. Michelle Alexander, she is a native Memphian. She's a graduate of East High School. She attended Howard University for her undergraduate institution and received her medical degree from Meharry Medical College. She completed her family medicine residency at University of Tennessee Health Science Center and was the chief resident in her final year. And she currently works as a hospitalist at Baptist Hospital. Dr. Danielle Tate is Associate Professor at University of Tennessee Health Science Center in Obstetrics and Gynecology. She received her undergraduate degree from Louisiana State University and received her medical degree from Howard University. She completed her residency at University of Tennessee Health Science Center and served as chief resident. She went on to do a maternal fetal medicine fellowship, and she's also currently the director of OBGYN. She's the director of obstetrics, infectious disease, and also high-risk outpatient services. And she has a specialty in caring for pregnant patients with HIV. Again, Dr. Tate is another individual that I say, how do you have time to do everything that you do? Not enough hours in the day. Dr. Kendra Shepard, she is trained in internal medicine and geriatrics. She did her undergraduate training at Howard University. She completed her medical education at Meharry Medical College. She did her residency in internal medicine at University of Louisville. She did her geriatrics fellowship at University of Alabama at Birmingham, and she works here locally in Memphis as the medical director at Dedicated Senior Medical Center in the Whitehaven area. And I will say that Dr. Shepard is working. She sent me a text saying that she had some patients that ran late, so she is going to be joining us a bit later. Dr. Chanello Alamalu is an infectious disease and internal medicine specialist. She also has a public health degree. She is assistant professor at University of Tennessee Health Science Center in the Department of Medicine and Infectious Disease. And she currently works on an inpatient basis at Methodist University Hospital. And then Dr. Calvin Greene. Dr. Greene is a Memphis native. He did his undergraduate degree he did his medical degree at Lincoln Memorial University, DeBusk College of Osteopathic Medicine. He completed his internal medicine residency at ETSU, and he currently serves as a hospitalist at Methodist Le Bonheur Healthcare. Oh, so not quite ready for questions yet. We will stop the sharing of screens and I will bring the panelists on. So first, I'm going to start with Dr. Lester. Can you um, come onto the screen, please? Because I'm so excited that we have the opportunity to have you here this evening. I had the opportunity to see the news story that was done on you um, in a few weeks ago, and I thought
Yeah,
it was remarkable. So
thank you.
thank you for joining us.
Thank you for having me.
So I want to take the opportunity to dive in because, you know, we are, as physicians, we are naturally inquisitive and wanting to know what was going on and what went on with you when you were diagnosed with COVID. So tell us, like, start off and tell us, like, when you were diagnosed with COVID,
Mhm.
what symptoms you had, and just kind of how your course went after that.
And well, thank you again for having me, and Dr. Washington, and good evening to all of the panelists and attendees. My journey with COVID started in July of last year. The last week of July 2020, I was diagnosed with COVID. My wife was also diagnosed. She tested positive as well. My symptoms, I really had no symptoms. I thought I was asymptomatic. My wife was showing symptoms. She was fatigued. She was loss of appetite, all of that. My symptoms were just very minimal, a little coughing, but I started noticing on the last day of the month, Friday, July 31st, my oxygen was kind of fluctuating. I have a pulse oximeter at home. We were checking our oxygen. I noticed that mine was fluctuating. It was going up, down, up, down. And Saturday, August 1st, I told my wife that I thought I needed to go to the emergency room just to get it checked. I was not having shortness of breath or anything like that, but my oxygen was dropping. So my wife said, hey, call the paramedics. Let's see what they say. They'll tell you if you need to go. And if you go, they can get you to the back sooner. I called the paramedics. They came to the house. They checked my oxygen, gave me a little bit of oxygen. It went back up. They said, well, we better take him with us. Went to the hospital. And about an hour after I got there, maybe they put a CPAP on me. And after that, they put me on a ventilator. And the next thing I fully remember after the CPAP, this was August 1st, the next thing I fully remember was them telling me it was the middle of September.
Oh my goodness. Wow. Now
Yeah,
that is pretty impressive. So talk to me about how much time was it between when you were actually diagnosed with COVID and then you had to go to the hospital? About how much time was it between there?
a few days,
A few
um,
days.
maybe 3 or 4 days. And the reason I went, the pulse oximeter, I tell people all the time, really saved my life.
Hmm.
If I had not had that at home, I would have had no way of knowing that my oxygen was dropping because I wasn't feeling the effects of it. I was not winded. I cooked breakfast that morning. I was helping my wife do some things. And, you know, I saw my oxygen dropping. And when it got down to the lower 80s and upper 70s, I thought, yeah, it's time to go.
Yeah.
And so it was actually about 4 days, to answer your question, after I received my test results, that
Mhm.
I went to the hospital.
Okay. And then, so you said you initially went to the hospital on July 31st, and on August 1st was when they placed you on the ventilator?
No, it was actually August 1st that I went to the hospital,
Okay.
and they put a CPAP on me, and then put me on the ventilator later. It wasn't at full capacity at that point,
Mhm.
but I was on one and remained on one for 42 days.
Wow. So, you know, I think that that speaks to the severity of COVID, like what COVID can do.
Yes.
Certainly, that is very concerning that when you were home, you didn't really have many symptoms, and
Um,
had it not been for you having your pulse ox, there was a way that you wouldn't have been able to do that. And
and
so, go
let
ahead.
me add this, doctor. We were doing everything we possibly could to be safe. We wore masks, we wore face shields, we watched where we went. We didn't eat out or anything like that. We were doing everything we possibly could. So I have no idea of how I contracted COVID.
My goodness.
None
Yeah.
whatsoever. And if my wife hadn't been showing the symptoms, I never would have known. I would have thought I was, fine.
Mhm. And so comparing you and your wife, so your wife, I'm assuming, didn't have to be hospitalized for COVID.
No,
And
she did not.
okay, and she recovered and did fine.
Yes, ma'am, she did fine. And also, after I was released from the hospital, they took me to Regional 1 from Methodist Germantown to wean me off the ventilator. And after I was released on October 7th from rehab at Regional 1, we discovered I had a leaky valve, heart valve, my aortic valve. And they didn't say that it was directly due to COVID, but they didn't say that it wasn't. And I ended up having to have open heart surgery to have that valve replaced. So COVID is very serious.
Right.
And, even now, having been on the ventilator that long, I'm still in therapy with my right hand, trying to regain the strength and work on those fine motor skills. And all of that was due to being on the ventilator while I had COVID.
So, Reverend Lester, I think it's very important that we talk about what life after COVID is like. So, are there some things that you were able to do before you had COVID that you're not able to do anymore? How has
Well,
your life changed as a result of your diagnosis?
well, let me say this. My pastor is Reverend Dr. Gina Stewart, and I had a praying pastor, a praying church, and a praying family, and I believe in the power of prayer. So I said that to say that with my pastor behind me, my family behind me, my church behind me, I'm doing very well. The only thing is my right hand, and I'm working on that. The fine motor skills, I'm having to, practice my writing a little bit more, and doing things like twisting doorknobs.
Mhm.
So outside of that, I'm doing very well. I've had no other issues with that. The issues were all while I had it. Had to
Mhm.
learn how to walk again, had to learn how to pronounce certain words again, had to learn how to swallow my food again.
Mhm.
And I'm still watching all of those things, but God has been good to me.
That certainly is a blessing. I do also want to kind of go back. So during that time when you were in the hospital, when you were in the ICU and on the ventilator, did you have a tracheostomy tube?
Yes,
Um,
ma'am, I did.
and did you have like a feeding tube in your stomach to be able to receive feedings?
Yes,
Okay.
had the tracheotomy. Um, the thing is, and you all are doctors, so they decided to do that on August 20th. I had been on the ventilator for 20 days at that point, and they said the tube has been in too long. We'll have to do the tracheotomy. And they did that. And the thing is, of course, I didn't know it. I was just totally out of it the whole month. And I didn't know I had it until like the first or second week of September.
Mhm. And so just for the individuals who are watching this webinar, understand that when patients go to the hospital and they have to be placed on the ventilator, they have a tube that goes down the throat. We call that the endotracheal tube or the ET tube.
Yes.
That tube goes down the throat, and really, we only like to leave that in for a short period of time. Really, about 3 weeks is the maximum amount of time because it can cause some damage to the airway. It can cause some damage to the vocal cords. So we really like to get that out after about 3 weeks so that there's not permanent damage to the voice box and things like that. So that's the reason that we go ahead and recommend placing the tracheostomy tube at that time. And then
Absolutely.
we're
And
able to work on weaning the patients from the ventilator at that time. And
right.
then, as Reverend Lester said, he had to have a feeding tube as well. We call that a PEG tube or a G tube. And basically, what that is a tube that sits outside of the body but goes directly into the stomach. So we can deliver liquid nutrition directly into the stomach to be able to maintain the nutritional status for patients when they're critically ill, or if they have issues with swallowing, or if it's a chance that they can't take enough food by mouth to be able to maintain their caloric needs. And so just understand that those are a couple of the things that had to occur for Dr. Lester to be able to be here with us today. And so we're
Yes.
very grateful of that he's here with us, and we're very grateful for
Thank you.
modern medicine.
Right.
And so tell us, and so you said, Dr. Lester, that they didn't confirm that the leaky valve was was the result of your COVID-19 infection.
No. Well, it wasn't said one way or the other. It was endocarditis, but of course, with COVID being so new and everything, they don't know when this leaky valve actually started. I had almost 40 pounds of fluid on me.
Hmm.
And they just did not know when it started, at what point, or what have you. When you're losing your breath and everything, you can't tell if it's due to COVID. When I first went to the hospital with that, they tested me for COVID again to see if that's what it was. And when the test came back negative, I had to see a cardiologist. My cardiologist is Dr. Lisa Young. And we did they ran tests and everything and found this is a leaky valve. We don't really know when it started, but we know we have to repair it or replace it, and we have to do it very quickly.
Mm-hmm, mm-hmm. And so before your COVID-19 diagnosis, you didn't have any history of any heart valve disease or heart valve problems that you knew of.
I had never seen a cardiologist before in my life.
Wow. Okay. Okay.
Yeah.
Yeah. And so, so Dr. Lester, let us shift. I do want to talk about, your experience, certainly as a COVID survivor.
Yes.
We are hearing a lot about the COVID vaccine right now. Tell me, what are your personal views on the vaccine and whether people should receive the vaccine after having lived through your experience?
I'm an advocate for the vaccine all the way. I think that if you can get it, get it. That's my personal opinion. We have, again, Dr. Stewart had a pop-up site administering the vaccine at Christ Missionary. I was there the whole time for that, trying to encourage people to go on and get it, to come out and get it.
Mhm.
Really and truly, we've heard some stories about the vaccine, but nothing major. At least I hadn't heard anything major. So I hadn't heard anything bad I have not heard anything bad about the vaccine, but I know what COVID will do to you. I know firsthand.
Exactly. Exactly. And then
So
also, just to ask you personally, have you and your wife received the vaccine? I know you
yes,
have several medical issues and now post COVID. And so tell me, did your doctor recommend that you go ahead and receive the vaccine?
we asked about that and they told us yes. And the first chance we had to get it, we got it.
Okay. All right.
We did receive it. It was in February. Actually, late January, we received the vaccine and the second dose in the middle of February.
Okay. All right. Good to know.
Yes.
And so just another thing, tell me about, as this pandemic has continued to move on, we've seen a lot of things. I'm sure your church, like a lot of other churches, had transitioned to virtual
Yeah.
services. I know people want to get out and start intermingling. Tell me what your thoughts are about them lifting the masking mandates here in the city over the past week. Tell me your thoughts about that.
You have people that wanted the mask mandate lifted, and you have people that didn't. And I think that both groups are satisfied at this point in that since it's lifted and people did not want to wear the mask, well, they don't have to, but it's lifted. And those of us who want to wear the mask, we can. I think that it's a little too soon, to be honest with you, to answer your question. However, the fact that it's been lifted does not stop me from wearing my mask. And I will do so. I will continue to do so for for a good period of time.
Absolutely. Well, Dr. Lester, we certainly thank you for joining us. He's going to stay on the call, and when we have our Q&A session towards the end of the event, Dr. Lester will come back to join us. And
Yes,
so now we're going to make the transition with our physician panelists. So we'll bring our physician panelists on to the screen. If you all could join me here on the stage, then that would be great. So I have all of my colleagues that I haven't been able to see since we work in different hospitals, but it's so great to see them all. So we have everyone here. And so we're going to kind of dive in. So we're going to use this really as an open panel discussion where we'll talk about a lot of different things. Anyone is welcome to chime in. Again, for our audience watching, if you have any questions, drop them into our Q&A section, and we're happy to answer them. Many of them we may already answer because we did receive some questions through our registration link. I know that Dr. Kendra was working, and she may not have the ability to share her camera right now. I had one question I was going to ask her specifically, but I will hold that question until later. But I do want to start off by asking you guys one question. So let's talk a little bit about things that people can do to protect themselves from COVID-19. Tell us, what advice have we been giving to patients for over a year to tell them how to protect themselves and to protect their family members against COVID-19? Anyone who wants to join?
I think Dr. Lester already gave us the main takeaway is to continue to wear a mask. You know, as a physician myself who's been vaccinated, I'll continue to wear a mask probably well into 2022, honestly. And I actually don't ever see myself coming out of a mask in the hospital. It's kind of mind-boggling that, you know, as healthcare workers, we were going unmasked for so long, unless patients were coming into the hospital with, you know, communicable diseases like, you know, TB or things like that. But even if you look at CDC guidelines, things like mycoplasma, you know, they recommend that we exercise droplet precautions when appropriate. So we were probably being a little bit, you know, lazy in the hospital. So wear a mask, appropriate hand hygiene. We've seen
absolutely.
how those issues themselves have drastically led to a reduction in seasonal influenza, not just, you know, coronavirus. So hand hygiene, mask wearing, avoiding large gatherings, and encourage others to get vaccinated. You know, I stay on my friends and family daily, almost annoying. So.
Absolutely. I think I probably lost some friends during the pandemic because they are sick of hearing me tell them about what they should and shouldn't be doing, or say I call somebody and I can hear that it sounds like a party behind them. I'm asking, like, what are you doing? Why? You act like the pandemic is gone. And, you know, so that's certainly important. Let's talk a little bit about. And so let's talk about what some of those conditions are.
I lost you a little bit right
Oh,
now.
I apologize. I did get a sign saying my internet connection was unstable for that moment. But what I was asking was, let's talk a little bit about pre-existing conditions that can cause individuals to have more severe COVID disease. If someone could comment on that.
All right. Things like, you know, congestive heart failure, patients that have either compensated congestive heart failure, CAD, that's coronary artery disease, those with underlying respiratory infections like cystic fibrosis or pulmonary fibrosis or asthma, or things that already at their baseline have caused some compromise to either the cardiac or the respiratory system, would be considered high risk. And this is because there's already some baseline damage to those systems prior to COVID coming in. So it kind of makes it worse.
Yeah, absolutely. I also wanted to highlight a bit the information that we have about really one of the highest risk factors for severe COVID disease was found to be obesity. And, we know that we live here in the Bible Belt and in the Deep South where we like to eat. And so obesity certainly is an issue for us in our communities. And so just understand that even if you may not have any other conditions other than being, overweight, that could also cause you to have more severe COVID disease should you be affected.
And you're absolutely correct, because in our facility, during the peak of COVID, majority of our patients, mortality was basically amongst our obese patients that got on the vent. It was extremely difficult to get them off the vent. So we consider that our number one top comorbid condition.
Even if those patients, and this is something that I've had to, say quite a bit since we've been dealing with it, especially, at Methodist North, even if these obese patients don't readily know about having health conditions such as diabetes or high blood pressure, typically there's an element of untreated sleep apnea. Sleep apnea is a respiratory disease. It leads to problems with your lung architecture, predisposing you to infection. So just because, you don't have high blood pressure or diabetes or congestive heart failure, there are diseases and, processes that are silent until they're not. Sleep apnea is one of those, and it's intricately linked with obesity.
Absolutely. So all of those, are very important things that we really should address. I did want to talk a bit about, the majority of patients who get diagnosed with COVID-19 won't have to be hospitalized, luckily. So when we are talking about treatments that are available on an outpatient basis, so meaning for patients that don't have to be in the hospital, what are some of those treatments that are available for patients to keep them out of the hospital as a result of COVID-19?
So let me speak from the ID perspective. In our clinic, when we have COVID patients, the first thing we do is to look at their risk for progression to severe disease, go back and look at the past medical history, see what they have. And if they have risk factors, for instance, the obesity, baseline CHF, COPD, pulmonary fibrosis, we consider them high risk for progression to severe disease. So those will be the patients that we immediately start them on monoclonal antibodies. Luckily enough, our Methodist, we do have an infusion center where we're able to send them and they get those treatment. And we found out that literally all our patients we saw in the clinic that we have given monoclonal antibodies ended up not requiring hospitalization. And I strongly believe that these are people that if we hadn't done that one way or the other, they would have been home. They would have been in the hospital, and who knows what the mortality would have been. So we continue to use monoclonal antibodies. There are 2 types available in our facility at this time, and we just risk stratify our patients. There are some people that come and they're completely asymptomatic, just like Dr. Lester has talked about. We make sure that they have pulse oxy at home, and we ask them to check for fever and see if there's any progression. Then we take it from there.
Yeah, absolutely. I think that the monoclonal antibody has certainly been very helpful in our communities to prevent hospitalizations of patients with COVID-19. Dr. Alamalu, can you talk a little bit about the availability of the monoclonal antibody? I know you said that you risk stratify them, meaning that not everyone would qualify to receive this medication. But is it available in multiple hospitals across the city? And how would you go about accessing it?
So yeah, it is widely available. There are two different types. We have the Regeneron. Some other hospitals might have a different type, but to access that, you have to see a physician, either your primary care doctor or your ID doctors. Most times they refer them to our clinics, and then when we started losing patients, to be honest, we got to the point where everyone that walked into our clinic, we're like, we're going to give you this medicine, because we had an unfortunate situation with a Memphis police officer who was completely fine. And we didn't think he needed the antibiotics. And we sent him home. 2 days later, he was admitted. After several weeks, he died. So myself and my partner, we just said, oh, you have COVID here. We're sending you off to the infusion center. But where we are right now, it's just people, again, that have those risk factors, and they're readily available from us and from other facilities. I know at Baptist it's readily available. You just have to, schedule an appointment, maybe with your PCP or with an infectious disease doctor, but we have them available.
Thank you for that information. Dr. Shepard, I'm glad you were able to join us from your busy workday. I know that early on in the COVID pandemic, you had worked with the patients in your practice and kind of developing these kind of COVID at home kits. Talk to us a little bit about what was in those kits and what was needed for your patients at home. We heard from Dr. Lester earlier, where he said he had a pulse ox at home, and that was really the only time when he knew that he needed to seek medical care.
Thank you. Good evening, everyone. Yes, and we still continue to use our COVID at home kits, because one thing that people may or may not know, that we're still diagnosing COVID. I've diagnosed 2 in the last month. So yes, the main part of the kit was having the pulse oximeter. We did also, I believe, put in an incentive spirometer. So to kind of teach them, okay, you need to take deep breaths, and sort of exercise your lungs, make them rest, because there were a few people that kept trying to do stuff, and we were like, no, don't do anything, you're at home, make sure you have the pulse oximeter, check it every day, 3 times a day. And if their oxygen saturation decreased, initially, if it decreased below 94%, they were supposed to call us, and we were shipping to the hospital. As we learned more about it, that number varied, whether they had a chronic condition like COPD or something like that, but certainly above 92%. We put a thermometer in there. So, hey, check your temperature. We didn't assume, that people have thermometers, because many don't. So we put a thermometer in there. And then we made sure that they had, cough syrup, and it's sort of like the supportive things that they needed. And we just tried to call them, every 2 or 3 days to make sure everything was going okay at home.
Yeah, I think that certainly is information that's much needed. I know when I first heard about COVID, I ordered those supplies for myself and for my family members, for my parents, aunts and uncles, and making sure that they had those things, that if they had any symptoms or had any concerns, that they would be able to check that out. So now I want to kind of make a shift and transition.
I'm sorry. I just want to also say that we also put masks in there, because people don't live alone, and so we wanted to make sure that the family members were wearing masks in the home, and we gave them written instructions. Okay,
absolutely.
Thank you.
That is essential too. Thank you for adding that. I do want to make a shift. Unfortunately, some people will have to be hospitalized for COVID. And 2 of our physicians, Dr. Greene and Dr. Alexander, serve as hospitalists, meaning that they are doctors that work mostly in the hospital. Dr. Greene is internal medicine trained and Dr. Alexander is family medicine trained. So I do want to kind of bring them on and let's talk about reasons that patients will have to be hospitalized with COVID. Dr. Alexander?
Yes, I think one of the first reasons would be low oxygen levels or hypoxia. And so that is one of the vital signs that we look at that would be one of the determining factors for hospitalization. Along with pneumonia, quite a few of the patients with COVID develop pneumonia, which in addition to having the viral process causes further compromise to their respiratory system. So having a low oxygen level, fever, pneumonia, difficulty breathing or dyspnea, along with having multiple comorbid conditions, which we've already discussed, would definitely be a reasoning for admission. I do want to bring up a side effect of COVID that we haven't really spoken about is the increased risk for the formation of blood clots. And one of the conditions that is very prominent in African American are autoimmune conditions like lupus, certain protein deficiencies, which can increase your risk for blood clots. And we know that this condition can increase your risk for blood clots. And we're finding not only are COVID patients coming in with pneumonia and low oxygen levels, they're coming in with blood clots in their legs, blood clots in their lungs, which in of itself can set off a whole another realm of medical conditions. So those things definitely would be reasons to be hospitalized.
Absolutely. Dr. Greene, anything to add? And so I know that Dr. Alexander talked a little bit about the blood clots, but also, you know, we were seeing a good number of COVID patients that came in with strokes as well. So can we talk a little bit about that?
Definitely strokes, you know, quite a bit of strokes can be embolic just from transient blood clot processes. We were also seeing, you know, I think my main concern was just to echo what Dr. Alexander says, are the blood clots, because blood clots manifest in different ways, one of which is strokes, another which, you know, blood clots in the lungs, PE. You can get blood clots that go into your kidney or to kidney supply, causing you to go into renal failure and ultimately need to be put on dialysis. We've seen that. We've seen clot burden so bad that people have lost limbs. They've had to get, you know, amputations, one leg, two legs. They go home on blood thinners. You know, one thing that kind of bothered me a little bit when the vaccines were rolling out is we kept hearing about people talking about the blood clot side effect profile, which is almost negligible. However, the clot burden associated with the disease process itself, coronavirus, is well known. We see it weekly, me and my 6 colleagues. So I agree with what you said.
Absolutely. And so tell me about what you all are seeing in your hospital. You know, we really have we have all of the hospital systems represented here on this panel, between St. Francis and Methodist, Baptist, and UT. People kind of chime in and let me know what you all are seeing as far as COVID numbers in your hospital facilities, because I know at the St. Francis hospitals, our numbers aren't quite as high as the peak, but they aren't very low either. And then we're seeing a lot of patients come in for other conditions as well.
Well, I'm with the Baptist system, and we definitely have seen a decrease in the total number of admissions. But I've noticed maybe over the last 2 to 3 months, a different presentation of the patients that we're seeing. And so I've noticed less of respiratory presentation and more of gastrointestinal presentation, where people are coming in with diarrhea, dehydration, which is leading to kidney failure, sometimes issues with the heart from the dehydration. So I've noticed a transformation in the presentation of the patients over the last maybe 60 to 90 days.
They're sicker than they were initially, you know, At one point last year, half my service was coronavirus. This week, I only have 4. But it does seem like that the ones that I have coming in now, they do worse, and ultimately they end up passing away in the hospital. So getting back to the overwhelming clot burden, we're seeing a lot of arterial thromboses, dialysis. I had someone go into shock liver a couple of weeks ago where they just went into fulminant liver failure. And there's just not much we can do, unfortunately, when you get to end stage organ disease. You have to be relatively stable to undergo dialysis, unfortunately. And sometimes the disease process is just so great that those patients can't undergo it.
Absolutely. Tell me about what you all are seeing as far as the ages of the individuals that have to be hospitalized. Are you finding that they are a little bit younger than what we were seeing earlier on in the pandemic?
Oh, I'll go. It's still a variety of ages. And one of the things I am seeing is young people with multiple comorbid conditions. And so young people are thinking, I'm young, this is something that's not going to happen to me. But you're young and you have high blood pressure, or you're young and you have diabetes, or you're young and you're overweight, or you're young and you have all of that and you smoke. And so being young is not necessarily a protector for getting this disease. And that's something that I have to, and young people from my experience are not as regimented about wearing their masks because they think they are protected based on their age. And so there's still a variety. I think I've noticed that our older patients tended to be more willing to get vaccines early out of fear. And so I've noticed a decrease in the number of our most senior patients, but our middle age to younger patients are still coming in at about the same rate from my experience.
Dr. Washington, can I say something to branch off of what Dr. Alexander just said?
Absolutely.
Okay. When I went back into the hospital for the heart issues and everything after COVID, one of the doctors that saw me while I helped take care of me, treated me while I was in intensive care on the ventilator, came and spoke with me. And he's a pulmonary doctor, and said, don't be worried about the surgery. I know you're concerned and everything, but you've beaten COVID. You've gone through life. You've been on life support, all of this, and we're going to get you through this also. But he told me the first week of December 2020, from March to December, 64 of us had come in with COVID and were placed on a ventilator, on life support. Only 6 of us made it out alive. And I'm 52, I just turned 52 years old. And most of the ones that did not make it were younger than me. So they had people in their 20s, 30s that did not make it. So I just wanted to branch off what Dr. Alexander said, and that, a lot of younger people may not be taking this as serious, but we really need to. We need to wear our masks. We need to get vaccinated. Younger people are dying. Of course, I'm a minister and deal with a lot of people. And I've had several people tell me that their younger relatives have passed away from COVID. I just wanted to add that to what Dr. Alexander just said.
Absolutely. Thank you so much for adding that. And I think that that's very impactful. So understand that what Dr. Lester said was that over the 3-month period, about 65 patients had to be placed on the ventilator, but only 6 of those patients survived. And that is remarkable. So certainly is a testament to what COVID can do. You all excuse my dog barking in the background. I'm not sure what's happening there. But I will also kind of come in and talk about, let's talk about the amount of crowding that's in the hospitals. Are you guys seeing that your hospitals are really full? Because I know at St. Francis, our facilities are relatively full at this time with, we have a good number of COVID patients, but we have patients with other conditions as well.
Yeah, we stay full at North. And I think it gets back to what everyone was just saying. here it's just not COVID. It has a lot to do with, the obesity epidemic that we have. And while young people tend to think they're invincible, we have an overwhelming young population at Methodist North that come in with untreated sleep apnea, end-stage heart failure, whose heart is pumping only 10 to 20% of what it should be. We have a lot of uncontrolled diabetics. We could start an entire wing of patients who abuse cannabis and come in with cannabis hyperemesis and, have fallout from that. So we're always busy. I think we're in the middle of a dialysis apex out there. We have quite a few DaVitas and Fresenius dialysis centers, and patients who can't undergo dialysis outpatient, due to hemodynamic instability, end up coming to us. We're close to Munford. We get the patients from West Memphis. We get quite a bit of transfers from Baptists that are Signum patients. So we are never not busy. That's why, we run just 7 teams of hospitalists at this point, and that doesn't include the private doctors.
Yeah, so you guys certainly stay busy. Dr. Alexander, what about the Baptist hospitals? I feel like I'm hearing that, most places are pretty full.
They are. We have started back holding people in the ER for days on end due to a lot of it has to do with staffing. We have rules on how many nurses can take care of so many patients. And so when you don't have the appropriate ratio on the floor, patients can get admitted, but not admitted to the floor. And so that leads to ER backup and holding patients in the ER. And I think the whole system has been tested and stressed throughout this epidemic. And but the remarkable, we've rebounded and found our footing and doing our best to do excellent care.
Absolutely. So I do want to kind of move the conversation along. I want to transition into talking a little bit about COVID-19 and children. And so Dr. West is going to talk to us a little bit about that. One of the things that I talked about was that children really have been relatively protected during this COVID pandemic, because back in early March 2020, they shut down the schools. And so kids haven't really been in that communal setting since that time. But of course, kids do have to go back to school eventually. Dr. West, can you talk to us a little bit about what are your concerns that you have surrounding COVID and children going back to school?
Well, first of all, I'd like to thank you, Dr. Washington and Bluff City Medical Society, for inviting me to give this information to you and all of the attendees. With the schools reopening, of course, there's the natural worry about increases in infection, just overall among children, adolescents, and adults, particularly those who have not been vaccinated. With those who've been vaccinated, we don't have much of a worry, but with coming into the schools, children and adults from different households where you don't know the vaccination status, and then there's participating in in-school activities as well as extracurricular activities such as contact sports. We worry about those folks who have not been vaccinated. For the unvaccinated, we of course hope that mask wearing, physical distancing, hand washing, along with persistent sanitization and cleaning of the schools will help to decrease that likelihood of disease spread, especially while vaccinations are still going on. Another thing that we worry about are, in this past year, of course, everybody was virtual. And so vaccinations may have fallen behind. And so those should be caught up. And actually, just yesterday, our pediatric infectious disease experts stated that with the types of vaccinations that children will need going back to school just in general, it should be okay to co-vaccinate, as you know, especially among those older children for which the vaccination is available.
Absolutely. I think that's very important to talk about, because we know that during the pandemic, you know, office visits in general were down. So some of the kids are behind on their vaccines. And so it's important that they catch up on those routine vaccinations as well. Dr. West, talk to us a bit about like what symptoms children may have from COVID-19.
Sure. So let me just paint the COVID-19 picture for you. So the first thing I'd like to say is that all children are at risk of infection of SARS-CoV-2. It's not just one particular group or another. There are higher risk groups. Of course, you know, if you've been exposed to anyone with COVID, that puts you at risk. But then there are the comorbidities that the same ones that put, or the similar ones that put adults at high risk for COVID are some of the same ones that put children at risk, including heart disease, obesity, asthma, and diabetes. As far as illness severity, the illness severity can range from asymptomatic all the way to severe illness. And asymptomatic, of course, means that there are no symptoms. And so those patients we tend to not worry about in the beginning. But then there are those patients who have mild symptoms that have a cold-like picture, and they can present with symptoms such as fever, just general feelings of being tired or not feeling well. They can have poor appetite or poor feeding for the younger children. They can have respiratory symptoms, just like adults do, with cough, shortness of breath. They can have a runny nose. And they have also been coming in with GI symptoms, such as diarrhea, nausea, and vomiting. And then there's the severe illness that can lead to hospitalization and potential death caused by organ failure, and it's called MISC, or multisystem inflammatory syndrome in children.
Yeah, you know, I think that one of the things that we heard about early on was this MISC, and just how terrifying that disease process is. So, you know, I know that the percentage of children who have COVID and develop this condition is relatively low, thankfully. But tell us what that disease process looks like, and, you know, what the typical hospital course would be like for someone who has that.
Right. So MISC again stands for multisystem inflammatory syndrome in children. It is essentially widespread inflammation of the organs, but according to the CDC-based research that was published in New England Journal of Medicine last year, the organ systems that are most affected are the GI tract and the cardiovascular systems. These children are less than 21 years of age. They have severe illness requiring that they be admitted to the hospital. Typically, they come in with persistent high fevers. They can have other COVID-like symptoms, and they have to have 2 or more organs affected. And they also have to have laboratory testing that serves as evidence of that inflammation. There's no evidence, there has to be no evidence of other diagnoses that affects them. So it's a diagnosis of exclusion. And then they have to be positive for COVID currently, or have had a recent COVID-19 infection, and or exposed to an individual with suspected or confirmed COVID-19 within a 4-week period. There's also Kawasaki disease. And I think there's been some information that has been out there saying that it looks very much like Kawasaki disease, and it does. Children with Kawasaki disease have an acute illness that presents with a lot of high fever that's persistent. They also have other symptoms as well, and some of those symptoms do overlap, especially heart disease or involvement of the cardiovascular system with MISC, so that they kind of overlap with each other. So that's pretty much a picture of MISC and what we've been seeing.
Yeah, and so, typically we would expect for children to not really have very severe disease. And so we know that in the last week, the FDA has expanded their emergency use authorization of the vaccine, the Pfizer vaccine, to children between the ages of between the ages of 12 and 15. I'm saying 2 because that is what I'm hoping, that soon children age 2 and up will be able to get this vaccine. But Dr. West, talk to us about your recommendations for children who are eligible for the vaccine to receive the vaccine, and what, if any, exclusions would you have? So what children do you think should not receive the vaccine?
Sure. So that has also been discussed amongst our pediatric infectious disease specialists at Le Bonheur Children's. And of course, the vaccinations for the adolescents ages 12 to 15 are recommended, especially because of the upswings over time of severe illness in those children. So those patients that we don't know, that should probably have a discussion with their doctor are those who have had MISC. MISC does occur in the adolescent population. And so because it's new and there's a lot of unknowns surrounding MISC, it's important to know that those patients will have to have a conversation with their doctor to see if that vaccination is right for them.
And then, so my next question is, what are you hearing about the younger age groups getting approved to be able to receive the vaccine? Have you heard anything about that?
So, to our understanding, those trials will happen. And once the evidence on those vaccinations for that younger age group is released, then we should be able to better answer that question. If those trials prove effective and safe, just as they have for the adults and the adolescent population, we, based on that evidence, I would certainly say that they may be recommended, but that just depends on what the evidence says.
I would like to say something real quick. St. Jude's is currently enrolling children less than 12 years for this trial. So some of my partners with young kids have enrolled their kids. The only problem is you don't know if they're going to be in the vaccine or the placebo. So spread the news. They're enrolling right now, and we're trying to get people to enroll their kids if it's something they are interested in.
Thank you for that information. That certainly is good to know. So for those who are in the audience or who may watch this video afterwards, they are enrolling children under the age of 12 right now at St. Jude for COVID vaccine trials. It will certainly serve as a way to be able to contribute to this pandemic, to have you or your children to really participate in those studies to prove the efficacy of the vaccine and the safety of the vaccine. So certainly that is a plus. I do want to also kind of make another transition. Let's talk about pregnant women and COVID-19 and pregnant women and the vaccine. We do have Dr. Tate on the line. So I want her to give us a few comments. You know, a lot of young women have opted not to take this COVID vaccine because they think that it can affect their fertility. And so that's been an argument that I've seen, you know, certainly going around on social media. Talk to us a little bit about that. What's your recommendation for women of childbearing age? And then what's your recommendation for pregnant women receiving the vaccine?
Thank you. I will say with confidence, the evidence that we have, that is limited, of course, as we know in all the fields, it has not been shown to affect fertility in any adverse way. So there shouldn't be any hesitation from women or their partners to be vaccinated if they are planning or at least not on any active contraception to prevent pregnancy. As far as pregnancy goes, it itself is a risk factor, independent of everything else that we've talked about so far. So pregnant women do fall into that high risk category, and it is very much so encouraged that they continue to practice the same safe practices that we've discussed: distancing, mask wearing. Usually a harder sell in pregnancy because they're already a little winded with the gravid belly there, but definitely encouraging them to continue to wear their mask and proper hygiene, things of that nature. As far as vaccine goes, it's as safe in pregnancy as it is outside of pregnancy. And in the big studies that were done prior to the release of the vaccine, there were a good number of pregnant women involved in that study, and they had no adverse outcomes, regardless of where they were in the pregnancy. If they were postpartum, if they were breastfeeding, that was all safe. So right now we do recommend. Of course, as with any other patient, we can't say one way or another if they, sway them in a way, since it is encouraged that they do seek all of the information that's valid as they're making their decision, but there shouldn't be a delay in giving a pregnant woman the vaccination because she hasn't discussed it with her OBGYN or sought counsel from some other expert, like an infectious disease doctor. With that being said as well, they just need to know that it is the same rate of positivity that we see outside of pregnancy. But when we talk about the complications associated with it or the chances, a likelihood of becoming sick, they're about 2 to 3 times more likely to be ventilated, to be hospitalized, to be placed in the ICU than your non-pregnant patients. So even if they are in the mindset, which I have a lot of patients that'll say, well, I'll just let everyone else around me become vaccinated or get their vaccine, and then that should protect me, right? It's not the same. They should be getting vaccinated as well. No increased risk of clotting. I know that comes up a lot as well because pregnancy is just a natural state of increased risk of blood clots. So that plus the vaccination will not put a patient at any more risk than she already has prior to pregnancy. So with that, it's still a hard sell. I do worry, I do get concerned a lot about patients because my patients are probably the ones who are having the most gatherings, right? And we see a big uptick a lot of times of positivity after a baby shower. Everyone needs to have their baby shower. Gone away are the drive-by Zoom baby showers. Everyone's gathering back to normal. And we're seeing that result. In this past month, I've had 3 patients hospitalized with COVID. One left the hospital pregnant and on supplemental oxygen because she did not get better. Also, patients have to realize, or just the community has to realize, pregnancy is an independent risk factor. And then we add on the other risk factors that we talked about now, which my patients are not immune to. They're still diabetic patients, they're still obese patients, and it's disproportionately higher in the African-American and Hispanic population. So they at times will start to stack on risk factors, making it even more of a high risk for them with COVID and pregnancy.
Absolutely. Dr. Tate, talk to us a little bit about what it looks like, or what your typical patient who's hospitalized, your pregnant patient who's hospitalized with COVID, what they look like and what types of symptoms that they have.
So typically patients will present, if they're symptomatic, with upper respiratory symptoms. We still see the classic things you've heard about, the loss of taste and smell. Oftentimes patients will ignore the earlier symptoms or the milder symptoms, kind of wanting to contribute them to pregnancy changes. But when you start to get a thorough history, you realize that they were exhibiting the symptoms of the URI symptoms, especially, and they just thought it was seasonal allergies, or I thought that's what happens in pregnancy. We do see a great number of patients who are asymptomatic and COVID positive, and that likely has to do with the fact that it's mandatory, at least locally in all the hospitals, that every pregnant lady is tested right prior to her admission, if it's planned for delivery especially, or when she's admitted. Now the pregnancy stay is very different for a COVID positive mom who is delivering. She is definitely put into isolation. And as of lately, in the past few weeks, we've seen the relaxing of the hospital policy of allowing a visitor. Some hospitals will allow visitors if they're vaccinated. Some will allow visitors. All visitors have with the rule of not being able to leave the room at all. When this all started, we were much so separating everyone, baby, mom, visitors. Now mom is allowed to have her baby in isolation. But of course, that does come with, if there's no visitor available, she has to then care for the baby all by herself in the room, and they're discharged to home. Breastfeeding is still encouraged as well. For patients who are COVID positive and pregnant but not delivering. So our sick patients in the unit, it can be very scary for them. They're there, we're monitoring the baby with no plans to really deliver. We have a lot of conversations in a multidisciplinary way with the other doctors involved with care. And really there is nothing that's off limits as far as treatment when you're pregnant. So we tell all of our colleagues to treat as they see fit in any way, and really delivery would come down to if she is in a compromising situation, mainly respiratory, and it becomes emergent. And that would mean at times even delivering at the bedside in the unit and not having time to get to the operating room or to labor and delivery.
Yeah, that certainly it sounds extremely terrifying to me, and I'm sure it's a very scary situation for those mothers who are affected with COVID and going into having to be delivered emergently due to those complications. I do want to make a shift because I'm keeping an eye on the time. And I want to start talking about the vaccine. You know, that certainly has been big in the news. So, you know, for a lot of persons of color, African Americans in particular, there are a lot of people who say that they don't want to receive the vaccine. And a lot of people cite the Tuskegee syphilis experiment. And they want to know if the vaccine is safe for African Americans in particular. Can someone kind of speak to that a little bit?
Yeah, so the vaccine is safe, and we can understand why there was some hesitancy, and there continues to be some hesitancy, especially in communities of color and other minority communities. It's very safe. We just last week, there was a lecture on, basically talking about infodemic, which is something that the CDC and WHO has formed this huge coalition with our social media giants, Facebook, Twitter, Telegram, and all those things. There were studies that came out of Harvard that showed that 80% of stuff you have on the internet about COVID were actually false and from, they call it, I think it's bots. And yeah, that's what they call that. And you don't have a lot of, authentic information out there. And so people are reading all sorts of things, conspiracy theories. And so when you add to all that mistrust, then, it makes sense why people are really hesitant. And also don't forget that this actually came out in the middle of the political drama. So some people thought it was just politicized and it was something that was pushed out there for people, but we continue to encourage our people. direct them to good sites to go look for their information, go to NIH, CDC, WHO, and don't. I mean, if you Google COVID-19 now, the first time, sites you're going to see are, not authentic. So this is something that we have to keep pushing. My mom, who has an ID doctor as a daughter, refused to get the vaccine because she said Russia said it's poison. I said, you are getting the vaccine. I don't care what you say, because she has her own comorbid conditions. So we still have to, help our people, our communities, and, encourage them and, explain the studies to them that the vaccine is really safe. When you look at the number of people that have passed away, that died in this last year from COVID, it's a no-brainer. So I think it's still part of our responsibilities to correct the misinformation that's out there. It's called the infodemic. And Facebook recently, that was about 2 weeks ago, with Amazon and Telegram or whatever, they donated hundreds of millions of dollars to WHO, to CDC, to help them fight this infodemic, which is spread of wrong information by the anti-vaxxers, as well as conspiracy theories out there.
I changed the view of the screen back so that we can kind of see everyone's video at this time, because I'm gonna just throw out a couple of questions, like some COVID myths that we've heard about. And so you can just look at everybody's facial expression, and we'll have one person kind of be representative and give an answer. So one of the myths surrounding the COVID vaccination is that if you get the COVID vaccine, that you'll actually get COVID. So who'd like to speak about that?
I can speak about that. So the COVID vaccine, you cannot get COVID from the COVID vaccine. And this is something we keep trying to explain to people. The mechanism of action is completely different. We're not using any inactivated organism, or, so there's no way it doesn't affect the DNA in any way, because it doesn't go through the nucleus, which is where the DNA is stored. So no, you cannot get COVID just from getting the vaccine. No.
Absolutely. I'm glad you talked about the DNA, because that was going to be the next myth. We've heard people have been circulating online that the COVID vaccine in some way gets incorporated into your DNA. And then I think we've also heard a little bit about if you get the vaccine, there'll be some type of microchip implanted into you. All of these are myths. These things are not true. I think that, seeing all of us here on the screen, I'll say just by a show of hands, who on the screen got the COVID vaccine. And I think all of us have received the COVID vaccine. So I think Dr. Greene's screen froze. Received the vaccine? Okay. All right. So just because, they'll screenshot this and they'll say, look, that doctor didn't get the vaccine, and that'll be proof that nobody should get the vaccine. So I just wanted to be clear there. So, we all know that after you receive the last dose of your vaccine, about 2 weeks after that, you are considered to have full protection from severe COVID disease. So, I do want to talk about that and the new recommendations from the CDC regarding vaccinated individuals. So, Dr. Chanello, can you talk to us a little bit about that?
Yeah, so absolutely. Let me give you a personal experience. Last weekend, my son graduated from high school and we went for the event. And I'm looking around, looking stupid, because we were the only ones in our mask. Everybody else did not have their mask. And when we stepped out, a family friend said, "Why are you putting on the mask? CDC said we shouldn't mask." So I was like, oh my God. And I was like, oh my God, I wish I had my N95 here. And I was telling my son, mask off, mask off, anyway. So yeah, with the new recommendation, if you're outside, you can take off your mask. If you're around, vaccinated people, you can take off your mask. But people should not forget that you can still pick up COVID, get coronavirus infection. Yes, with the vaccine, you don't expect to have severe disease, but we still encourage people to continue with their mitigating factors. Wash your hands, do your hand hygiene, wear mask if you're going to be in an enclosed space without proper ventilation. If you're outside, and you can maybe, stay away from people or, try to maintain some distance, that's good. So I think people are everybody's so tired of wearing masks and everything. I think people are just tired. And so once that came out, by Saturday, we went for my son's graduation. There was nobody in their mask, and so, but we have to continue to educate our people and let them know, yes, you can still get you can still pick up the virus and you can still pass it on to people. So just continue to practice mitigating factors where possible.
That is so concerning, because I know people have what we call COVID fatigue, what we termed as COVID fatigue. And we might be tired, but COVID is not tired. It's still infecting people. People are still being diagnosed, hospitalized, and dying from COVID on a daily basis. And so I understand that a lot of the states have lifted the mask mandates. I understand that they also have the rules that vaccinated individuals don't have to be masked. I don't trust people because that there are people who are walking around in the stores and in those enclosed spaces who have not been vaccinated. And so, wearing a mask protects you and protects others. And so that is the reason why I think for all of us who are on this panel that we plan to continue to wear our masks when we go into public spaces, because we can't, I am responsible for me and for my loved ones, but I can't control what other people do. And so you can't assume that everyone that you're interacting with on a day-to-day basis who is not wearing a mask actually has been vaccinated, or if you ask them if they will actually tell you the truth about that. And so that is the main thing that I want to highlight. Dr. Lester, you wanted to make a comment?
Yes, I did, Dr. Washington. Thank you. I want to say this to the attendees. If you have not had COVID and had a hospital experience with it, you're blessed and you do not want it. I would advise everybody, I agree with Dr. Greene, at least for the rest of this year, I will wear my mask, and probably half of next year. I did not go into the nightmares, the hallucinations, learning how to walk again, having to learn how to swallow, just waking up in a hospital and you have no idea where you are, how you got there, where your loved ones are. That's real. That's what COVID presents. I spent 100 days in 2020 in the hospital. Before then, I had never spent a night in the hospital. So I'm saying this, wear your mask, wash your hands, encourage your loved ones to get the vaccine. Get it if you hadn't had it. I mean, I really don't, I don't just want to put it like this, but for lack of a better presentation, I don't care what the government says about lifting the mask mandate. You have to care enough about yourself, about your loved ones, about others, to wear your mask in public. Lower your chances of getting this deadly disease. Almost 600,000 people have died in this country from COVID, over the past 14 months. So we have to take that into consideration when we're deciding on whether or not we're going to wear our masks. As it's been said to me, it's just a no-brainer.
I agree. And you see, you see us all nodding. We are part of the Amen choir. So we definitely, look, your final word here from the non-physician on the panel, but we all agree with those sentiments.
And can I say one other thing, Dr.
Yes,
Washington?
sir.
You said the non-medical doctor on the panel. My doctorate is in ministry. So I want to say this from, the spiritual aspect of it. you have people saying, I'm not going to get the vaccine, I will just trust God. But God can work in different ways. And a lot of times, you know, the healing is supernatural, but God uses modern medicine and people like yourselves to help us in our healing. So the vaccine is not just from man, that's from God. We prayed about a way to get rid of COVID or to lower people's chances of getting it. And the vaccine is the answer to a prayer. So don't just rely on the supernatural as far as, oh, I just won't get it because God is watching over me. But God has provided medical personnel, scientific minds to create this vaccine to help us to do better and get better.
Again, the Amen choir. So I will say, any closing points from anyone on the panel? I'm keeping an eye on the time. We haven't really had many questions come through. I think that's because we're answering them in our normal kind of conversations. But yeah, just hop on in and chime in for us.
I just want to thank Dr. Lester for his comments and for his amazing story. It's always so good to hear. And I just wanted to end, you know, I work in a practice of older adults, age 55 and older. Many of them are committed to wearing their masks. Many of them have gotten vaccinated. And one of the things that we say as a company, you know, is that we say, choose love and wear a mask, choose love and wash your hands, choose love and get the vaccine. And we are here to answer any of your questions and concerns, and we'll help you through it. Good night.
Any other comments?
Yes, I'd like to say something real quick, because I don't think we can talk about COVID now and not mention the new variants that are all over the place. So there's so many concerns of people are freaking out about the new variants if the vaccine actually covers the variant. So from the South African strain to the UK strain to the, you know, what's it called, the Brazilian one and all that. So far, we know that both the Pfizer, the Moderna, and Johnson & Johnson do cover those strains. So that is not a reason for people to not get their vaccine. So please go ahead and get your vaccine in spite of the variants that are out there.
Absolutely. Any other comments?
I'd just like to speak about, I didn't hear anybody talk about hesitancy about the speed of the development of the vaccine. To say that mRNA vaccines have actually been around for decades, they've just not been used on the worldwide scale that we've used them during the COVID outbreak. And I really think people need to look at the ability to solve problems when worldwide minds get together and they get the money behind problem solving. And rather not say, well, how did this happen so fast? Ask, well, why can't we solve other problems like this with being united and coming up with a solution?
I totally agree.
I want to echo what Dr. Alexander just said. As a physician scientist, I will vouch for the scientists who came up with the vaccine so quickly. Again, she's right. This technology has been around for over 2 decades and has been used for other viruses, for vaccines against other viruses. So please don't doubt the scientists. They do care about you and they care about your health. And one thing I'd like to say about children, COVID does happen in children. It impacts children, and children can die from MISC. We've seen it. And so please wear your mask, wash your hands, protect your children.
And I guess just from the hospitalist standpoint, I guess a repeating mantra that I say in the hospital is, you know, make sure you're going to get your yearly annual, because unfortunately in life, we're fine until we're not. You know, my dad passed away from colorectal cancer in 2014. He was fine until he wasn't. He was perfectly healthy until he was not. So going to the doctor is how you find out whether or not you're pre-diabetic or diabetic. That's how you find out whether or not you need to be tested for sleep apnea. That's where you get your blood pressure monitored. So the annual visit is important. It can save your life in more ways than one.
And then Dr. Tate, do you have any final comments from an OBGYN perspective?
Sure. Again, like I said before, I really encourage that all of pregnant women don't hesitate to get the vaccination. Again, making sure they have all of the correct evidence as they make that decision. And recent studies have been showing, evidence is showing that they're seeing those antibodies crossing over to the fetus. So this may actually in turn, as time passes, show that we can provide protection to the unborn baby versus harm to the unborn baby in the same sense as we do the Tdap vaccines in pregnancy. So I see great things on the horizon. And also, just as I tell my patients every day, let's just together embrace this new normal and not feel as if we're still being punished with having to behave differently. But it's just as it with other big major evolutions in time, we have to embrace this new normal of living post-pandemic, and we can do it, and we can do it safely and still be happy and healthy.
Absolutely. So I thank you all for joining us. Again, you know, please understand that we here at the Bluff City Medical Society, we are really committed to educating our community. You know, if there is something that you want to hear about, let us know. We're happy to provide a webinar series. After this webinar, for those who registered on Zoom, you will receive a post webinar survey. You know, certainly include that information on things that you'd like to hear about. I'm gonna go ahead and share my screen once again, because, you know, we got through questions, although there weren't many. So know that, so June is Men's Health Month. We will be having a men's health webinar on Thursday, June 24th from 6:30 to 8 p.m. The registration screen is listed, and also utilizing that QR code that is on your screen. I will give you guys a moment in case you want to screenshot this, or if you want to go back and screenshot this information so that you can join us for the men's health webinar. We know that that is something that is very important in our community. Also, that's just another flyer for the same men's health webinar that will be occurring. And then I thank you all for joining us. Again, follow us on social media. Visit our website, bluffcitymedicalsociety.org. We're happy to be there to assist you. Also know that our previous events are listed on our website under the events tab. It will take you to a YouTube link where you can view the full video. We had a COVID webinar earlier in the year, and last month we had a mental health in the Black community webinar that's also listed. And certainly it was an excellent event. Again, I want to make sure that I take the time to thank our community partners, you know, all of the hospitals, health clinics, and the social organizations who have joined us in partnering to help get the word out about these very important health topics. And so I thank you all for joining us tonight. And again, please provide us with any feedback. If you enjoyed this, like the video, share it on social media, share with individuals who are in Memphis, who are outside of Memphis, who are all across the world, because this information is very pertinent and timely. So thank you, everyone. And you all have a good evening.
Good night.